Yeah, good evening. You're watching Dr. KK's Med Talk non-stop show. Welcome to Med Talk's live conversations that matter, an educational initiative supported by Eli Lilly. I, Dr. Preeti Mrinalini, am your host for today's session. So today is a very interesting topic. It's about obesity. Now, obesity management has evolved dramatically over the past decade. Today, physicians recognize obesity as a complex chronic disease rather than just a consequence of poor lifestyle choices. Now, along with lifestyle modification and on anti-obesity medications, metabolic and bariatric surgery has also become an evidence-based treatment that can improve and even reverse obesity-related complications like diabetes, hypertension, obstructive sleep apnea, even fatty liver, for that matter, even PCOS and infertility, and many more other things. Now, today's discussion aims to answer these very common questions, so please keep them coming. And we are here to clarify a lot of misconceptions and to help our viewers understand when bariatric surgery should be considered as a part of obesity care. So let's start the session. Kindly play the video. So here are today's key updates. So there is a large observational studies continue to demonstrate that metabolic surgery substantially lowers the long-term risk of cardiovascular events and cardiovascular mortality in people with obesity. Head-to-head evidence shows bariatric surgery still achieves the greatest long-term weight reduction. We're talking about 35% of the total body weight. Although newer GLP and dual GIP have definitely narrowed that gap. Now, evidence shows metabolic surgery can lead to regression of liver fibrosis, even resolution of MASH, that is metabolic dysfunction associated steatohepatitis, highlighting benefits beyond weight loss. Now, research suggests that undergoing metabolic surgery earlier in the course of type 2 diabetes increases the likelihood of diabetes remission by preserving pancreatic beta cell functions. Now, AI-based tools are beginning to assist clinicians in predicting surgical outcomes, identifying patients at risk for complication, and even personalizing the long-term follow-up. So, bariatric surgery for who, when, and how. Let's get into the topic today. So, I'm Dr. Preeti Mrinalini. I'm a laparoscopic bariatric and a robotic surgeon. So, today, let me introduce the guest for today. We have Dr. Manoj Jain. Dr.
Hi.
Manoj Jain is a highly distinguished pioneer in advanced metabolic gastrointestinal care and currently is the Senior Director of GI Bariatric Laparoscopic and Robotic Surgery at Nanavanti Max Super Specialty Hospital, Mumbai. With over 25 years of exceptional clinical expertise, he has successfully performed over 7,000 advanced surgeries, earning a flawless reputation for clinical precision and rapid patient recovery. His elite medical credentials include MS from Chem Hospital and MRCS from Edinburgh, alongside advanced international fellowships in complex robotic and bariatric surgery from South Korea, Germany, and Taiwan. Highly respected for his leadership, Dr. Jain is dedicated mentor who trains future surgeons and is widely recognized for combining cutting-edge surgical innovation with a deeply compassionate patient-first approach. So welcome, sir.
Hi, Preeti. Hi. How are you?
Hi, sir. Good, sir. How are
Good.
you?
Yeah, yeah. So we'll start with my favorite topic, that is bariatric surgery. Yeah. Then
Yes. Yes, sir. First of all, just for our viewers to understand, what exactly is bariatric surgery, sir? Is that one surgery or is it a group of surgeries?
so bariatric surgery is the GI surgery where we modify the GI tract. We modify the stomach. We modify the intestine. and because of this modification there are some changes in the gut hormones, and because of the changes in the gut hormones and the hunger and the appetite, okay, then there is a gradual weight loss because of the change in the alimentary canal.
All right, sir. So who do you
And
think? Yes, sir.
these surgeries are done laparoscopy as well as robotically. So basically these are our scientific GI surgeries. Okay.
To treat obesity and
Yeah.
obesity-related illnesses. Yes.
Yes.
Okay, sir.
Yes.
Sir, who do you think qualifies for bariatric surgery?
So bariatric surgery is usually indicated for patient whose BMI is above 37.5. Okay. So basically the obesity is calculated in terms of BMI. So in BMI, it is a ratio of weight and height. Okay. So weight being, the height being constant, as the weight increases, the BMI also increases. So we have a patient, the normal BMI is around 18 to 22.5. Then we have overweight, then we have different grade of obesity: grade 1 obesity, grade 2 obesity, grade 3 obesity. So any patient who is above grade 3 obesity, that is 37.5 BMI without comorbidity, or 32.5 BMI with comorbidity, that is diabetes, blood pressure, hyperlipidemia, any two diseases. Also, if the waist circumference is more than 90 centimeter in male or 80 centimeter in female with a BMI of about 30, is also considered as candidate for bariatric surgery.
All right, sir. Sir, so do we think or assume that surgery is only for the extremely obese?
No, it is not for extremely obese patient. Okay, extremely obese patient means patient whose BMI is above 50. Okay, they are called super obese or super
Okay.
obesity is there. But we have seen in India the visceral fat of Asian countries is little higher than the European countries. So we have lot of comorbidity at the lower BMI also. So we have seen lot of patients with a BMI of 27.5 having diabetes, blood pressure, and other comorbidities.
Yes.
So to treat this comorbidity, also we have to do bariatric surgery at the lower BMI also.
Yes.
So we at our institute, or the institute where the high volume is there, we are treating low BMI also for to treat this comorbidity. These are called metabolic surgeries. So
Yes.
where we treat low BMI diabetic patient or patient who is having high triglyceride, but the BMI is between 27 to 32, still we are operating the patient because of the comorbidity. So it is not
Comorbidity.
only for high BMI, but it is also for grade 1 and grade 2 obesity if they have lot of comorbidity, to treat the comorbidity.
Okay, sir. So, out of curiosity, what is the go-to bariatric procedure for you, sir?
So there are a lot of obesity surgeries which have evolved over last 30 to 40 years. Okay, so the most commonest bariatric surgery is sleeve gastrectomy, where these are all laparoscopy and robotic surgery. You don't have to cut the body because patients are
Yes.
afraid कि मुझे काटना पड़ेगा. But these
Huh.
are all keyhole surgery or laparoscopic surgery. So in there are about 9 to 10 different types of surgery, out of which the most commonest surgery is sleeve gastrectomy, where you remove the lateral part of the stomach and you don't change the intestine. So there is a calorie restriction. So instead of 800 to 1000 ml, your calorie is restricted to around 80 to 100 ml. And then we have a bypass surgery. So there are different bypass surgery: Roux and Y gastric bypass, mini gastric bypass, and now we are having sleeve plus surgeries also for low BMI
Yes.
diabetic patient. So there are a
Yes.
lot of different. So we have to tailor the surgery depending upon the patient BMI, patient
Yes.
age, patient comorbidity, okay, patient nutritional factors like whether the patient is vegetarian, non-vegetarian. All this we have to take into account and then decide which type of surgery to be done.
Got it, sir. Got it. So, how does this bariatric surgery lead to weight loss? I know you mentioned that there are some gut hormones
Mm,
that are affected and all of
mm.
that. So, I have a very this thing question. So, when we say sleeve gastrectomy, all around the globe, sleeve is a very commonly practiced. Even though
Yeah.
bypass and everything is
Mm.
evolving more than sleeve, because sleeve there's nothing much to evolve, but bypass is really evolving, but sleeve is very, very commonly practiced. So, do you think it's purely a restrictive procedure or there is some amount of metabolic effects as well?
restrict sleeve gastrectomy is more of a restrictive surgery, but then still you have lot of what you call gut hormone release in that surgery
Yes.
also, because the food reaches the ileum, the intestine, fast. So definitely there is an increase in the GLP and
Yes.
GIP, the gut hormones, and because of that we have seen lot of patients who have improved their diabetes and other comorbidity, or even with
Yes.
sleeve also. But
Yes.
the only problem with sleeve surgery is that there is little weight regain. If the patient is
Ah,
not compliant, then after
yes, sir.
few years, the weight regain is little higher side.
Higher.
So no doubt that sleeve is called restrictive, but definitely it also has a little metabolic
Has
effect.
a metabolic effect. Yes, sir. Another question that I have is, how exactly does it lead to weight loss? One is
Yeah,
restriction, one is the
yeah,
gut
yeah.
hormones. Are there any other effects here, sir?
Yes. So people think that just by reducing the calorie you will lose weight. It is not like that. Okay. So there are a lot of gut hormones which play this metabolic syndrome. Okay. So there are ghrelin hormone which is secreted by the stomach. Then there are few unknown hormones which are secreted with the first part of the duodenum. Okay, like gastrokinin and other hormones. Then there are hormones which are secreted by the intestine, that is GLP, GIP, and the PYY. These are the most researched gut hormones. And then there are adipose tissue, the adiponectin and the leptin. These are secreted
Leptin.
by the visceral fat. So there are six different type of gut hormones. So what happens whenever there is a bypass, whenever we shorten the intestine is about 6 meters. Okay, so whenever we do a bypass surgery, we shorten the small intestine so that the food reaches from the stomach into the terminal ileum within an hour. Okay, less than an hour. So what happens? These gut hormones are increased in the body, and they act on the pancreas to increase the insulin level. So whenever the
Yes.
insulin level is increased, this insulin act on the liver, and the glucose metabolism is changed. So even if you eat, this glucose will not convert into the calories. Okay, so there
Yes.
is a restriction, and there is a malabsorption also, and there is a gut hormone changes also. So all
Correct.
this causes
Yes,
weight
sir.
loss. So what is the weight loss? So you lose around 60 to 70% of the excess weight, or
Yes.
25 to 30% of your excess weight over a period of 1.5 years. Okay, it is not
Yes.
a sudden weight loss. Okay, there is a gradual weight loss, and it is a percentage weight loss over a period of 1.5 years.
1.5 years. Yes, sir. Yes, sir. I'm sure like you get asked this very often. So, what are the risks involved?
Risk. So basically, now the bariatric surgery is evolved over the last 15 to 20 years in India also. Okay. So initially, there were risk in all surgery. There is risk in gallbladder surgery also, risk in appendix surgery also. But now, because of the advanced technology, the risk is less than 0.1%. Okay. The risk is same as compared to the risk of other surgeries. Yeah, there is
Yes,
a risk. Okay, but now because we are able to manage the complications, okay, the mortality and the morbidity is less than 0.1% now. So the
yes,
most common risk is bleeding from the staple line or the leak. Okay, so and there are a few other what you call complications like DVT and pneumonia and that all, but that can be managed. The most important is the leak and the bleeding.
surgical
But with the
complication is
newer
bleeding
stapler
only.
and
Yes, sir.
yes, and with the newer staplers, that is robotic staplers and newer staplers, we the risk of bleeding and the risk of stapler leak, and because we have improvised our technique also, okay, and we know how the stapler works and how we have to fire the stapler and how we have to dissect. And because of the image also, the 3D image and the magnification, the risk of bleeding, the risk of complication has reduced drastically over a period of last 4 to 5 years. Okay, now it has come less than we hardly hear about one or two cases all over India, and we are doing
Yes,
more
sir.
than 10,000 cases in India
Yeah.
itself.
In India,
Okay,
yeah.
like that.
Yes, sir. Yes, sir. Now these robotic staplers are also AI
Yeah,
powered,
build.
right, sir?
Yes,
They find the tissue depth and
yes,
they alter accordingly itself, making it even
yes,
more precise. Yes,
yes.
yes, sir. So another question is, so how many days? I'm just curious, sir. So how many
Yeah.
days do you keep the patient in the hospital, sir, usually?
So usually, sometime if there is a young patient, we discharge the second day. If there is no comorbidity and we are doing simple sleeve surgery, then next day also we discharge the patient on clear liquid. But if I am doing bypass, then I keep the patient for 48 hours post surgery so that he pass flatus, okay,
Latest.
and the intestine start moving. Okay.
Yes.
Now the post op care is same like other what you call other surgeries, but in only this bariatric surgery we have to careful about the nutrition part. Otherwise they are
Yes.
able to walk, they are able to do their routine work, they are able to do their exercise, free hand exercise. Okay, the only problem is that in this surgery you have to follow the diet for next 3 weeks. Okay, that is very important. Otherwise the patient is discharged within 48 hours maximum.
Okay, sir. So, what kind of diet do you advise, sir? So, pre-op, how long liquids? Post-op, how long liquids?
So basically, in my practice, I keep the patient on liquid diet for 48 hours. Okay.
Okay.
And then post surgery, next day we start with water. And from the second day, for 1 week, we keep the patient on clear liquid so that the
Okay.
staple line, okay, is fused. Okay. So there is no chance of leak. And then for 1 week, we keep our patient on high protein liquid diet. Then 1 week, we keep on soft diet. So eventually, after 3 weeks, patient can eat everything, anything in a small quantity. So instead of eating a full pizza, they will be able to eat a small 1 or 2 piece of pizza after 3 weeks
Yeah.
from the surgery. So that is
Yes.
the okay. So instead of a full sandwich, they will be able to eat. So they can eat everything, anything in a small quantity.
Very nice. So, when you say 3 weeks of liquids, sir, how do you think is the compliance? Sir? Do you think patients are complying with 3 weeks of liquids?
So usually, whenever the patient comes to my OPD, okay, I explain them that this will be your protocol. Okay, this will be your diet post surgery. So usually, if they are able to eat liquid, okay, and some what you call soft diet, they are usually there is no problem in the compliance. So what I tell them, don't be social for 3 weeks. Don't go to party. Don't go for marriage. Okay, because otherwise you have to carry your own stuff.
Yeah,
Okay, so if you are not social, if you are at home, then you will be able to manage with this liquid and soft diet.
that is very true. Very true, sir. So this is what is the percentage of? Before this, do you give them any supplements? Any particular supplements?
Mm, yes. So usually what happened that the post surgery the patients are on liquid diet, okay, and then soft diet, okay, and there is a calorie restriction. The amount of
Yes.
food which they are taking is restricted. So definitely they will have some weakness. Okay, they will have some calorie what you call protein loss. They will have some vitamin loss. So what happened? The body can manufacture your fat and carbohydrate, but they cannot produce vitamin and protein. So you have
Yes.
to supplement the patient with protein and vitamin. So the protein should be around 1 gram per kg body weight, and multivitamin we add all the multivitamins. Okay, in a single tablet also you can get all the multivitamin, that is the common vitamin B, C, A, and D, and all that. So one multivitamin tablet and a protein powder of 1 gram per kg body weight is required for next 6 months to 1 year till the patient loses their weight. So normally the patient lose weight up to 1.5 year. So I tell the patient that at least for 1.5 year you have to take the supplement. Then in bypass surgery, I tell them to continue for lifelong. But in sleeve, usually the patient can skip little of the protein and vitamin. But if they continue the protein and vitamin, they will not have sarcopenia. They will not have sick look. If they don't
Yes,
take
sir.
protein, they will have hair loss. They will
Yeah.
look sick. Okay, and then they will not feel better. So the most important thing which I tell the patient is the nutrition part. Okay, that you have to follow the diet for 3 weeks, and after 3 weeks you have to continue the protein and vitamin. Even if you don't eat chapati, even if you don't eat your what you call tasty food, you the protein and vitamin
You
should go
have to
inside.
take the vitamins.
Yes. Otherwise
Yes,
you will
sir.
be sick, and which we don't want.
So, any particular, out of curiosity again, any particular brand that you generally prescribe, or is just the general generic vitamins? Because in India,
Uh,
bariatric vitamins are very less, though the requirement, according to all our books and everything, is much higher in a bariatric, post-bariatric patient.
mm.
But we're not able to get that particular amount in the
Yeah.
vitamin.
So
No, sir?
yeah, so there are a lot of bariatric, post-bariatric, what you call nutrition supplements are available. Okay, but
Okay.
usually what happens, it is not available everywhere, and usually the
Yes.
patient doesn't want to take that. So what I
Yeah.
tell them, at least take one vitamin tablet, one calcium tablet, okay, and
Ah,
one vitamin D3 tablet every
yes.
week. Okay, so this is
Yes.
minimum. And sometimes iron tablet also, if they are not able to eat what you call iron rich food. So this,
Yes, sir.
but if they take what you call a particular bariatric what a formulation, then it is
Yeah.
good. But
Good.
every patient cannot
But it's not
get that
available
and cannot
here. Yes,
afford
sir.
that.
Not yet. Yes, yes.
Yes,
And what do you think
yes,
about this
yes.
B12 deficiency, sir? B12
Yeah, so
post.
it is common. If you, yeah, it is common. And so B12 deficiency is common. Then thiamine deficiency, if the patient is
Yes,
having
sir.
persistent vomiting, okay,
Yeah.
then or not able to eat, then thiamine deficiency is also very common, which is irreversible if you don't treat it. So that's why
Yes.
vitamin B1, B6, B12, okay,
Yes.
and B9 folic acid, I always supplement, and along with the calcium and vitamin D3 and protein. So this has to go. Even if they don't eat, their liquid diet is okay. But these few things, okay, they have to take
It has to be
daily
followed.
and ritually, and for at least 1 to 2 years.
Yes, sir. Got it. So, any psychological role is
Hmm?
there? Do we need a psych evaluation before or after surgery? Do you think psychology has a role to play here, sir?
Yeah. So usually pre-op you require in some patients. Okay, like there are some young patient who are binge eating. Yeah, binge eating. Then some patient who are very anxious or having what you call suicidal tendency also because of their overweight. Okay, they are not happy with their, and there are a lot of body shaming going around in the society. Okay, and then body shaming from the family member also. They have a lot of anxiety and depression. What you call symptoms before surgery. So when the patient comes to our consulting room, we see that, and if we find any of these symptoms, okay, like anxiety or depression or something, then definitely we have a pre-op evaluation. If the patient is having high volume food, okay, or binge eating or high calorie food, okay, definitely we take a psychiatric opinion. And if the patient already is on psychiatric medicine, then definitely you have to take a pre-op evaluation. Post-op
Evaluation.
also around 5 to 10% of the patient will require
Definitely
psychological
require.
this.
Yes, sir.
Yeah.
So as I said that
Mm.
gut brain axis, for a lay person,
Yeah. But
they
Preeti,
talk a
I will
lot.
just
Yes,
Preeti, 1 minute.
yes,
I will just add to the psychiatric. Yeah, there are a lot of
yes,
psychiatric patient who are on psychiatric medicine before the
yes,
surgery.
sir. Yes,
But
sir.
I have seen that with the weight loss, okay, their well-being is come back. Okay, the
Yes,
inner well-being, okay, is come back. They are more happy. And I have
yes.
seen few of the patients who have gone off from their psychiatric
All
medicines.
the
Okay, they are
psychiatric.
gone off from
Yes.
what you call depression medicine. Okay,
Mm.
and this have motivated me to do more of bariatric surgery at lower BMI also for this type of patient, especially the
Yes.
young patient who are college going or you have just joined the job, and they are getting a lot of anxiousness because of their weight and not able to do their daily work in the office, and because of that they are going into depression and all that. So with weight loss they have stopped their medicine.
Yes.
So that I have seen
Yes.
a lot in my patient
Yes, sir.
series. Yeah.
That's very true. Scientifically,
Yeah,
also, we feel that with all the gut microbiome that is
yeah,
altered,
we get
the
them.
mood
Yeah.
gets elevated. Yes, sir.
Yes.
Yes, sir. So scientifically, also, it's true, and with the physical appearance, they are also very much
Yes, yes,
happier.
yes,
Yes, sir.
yes.
So let's talk about fertility and obesity. So,
Yeah.
what is your take on that, sir?
So it is quite related to each other. The obesity, the PCOD, the infertility, okay, is related to each other. Okay, as the obesity increases, definitely the PCOD, the hormonal changes are there, and the infertility is there. So in my, I have a few patients, okay, who are infertile because of the severe obesity. Okay, recently I operated matlab, around 5 years back. I operated one patient who was not having matlab, was having issue with a child. Okay, and she was infertile. I have done a lap chole many years back. Okay, so she came back to me saying that she is infertile and all that. In fact, the gynecologist had referred to me, and after surgery, so she has adopted one kid. Okay, because of the infertility and all that. But then she finally decided that she wants their own child. Okay, so they came to me, we operated, and after 2.5 years, she got pregnant because she has weight loss.
Yes.
So because of the weight loss, the hormones, the gynec hormones, that is all are improved, and the PCOD
Yes.
also improved. The gynec hormone also improved, the endometriosis improved, and because of this improvement, okay, the patient become fertile again. So there are a lot
Yes.
of papers, lot of series also which have shown that after weight loss, after basic weight loss due to bariatric surgery or due to drugs, okay, if there is significant weight loss, the patient will gain their fertility back.
Yes, yes, sir. So, what is your take about the new GLP-1 drugs? Where in the picture do they come, and where do you advise your patients saying no, go for bariatrics, don't go for GLPs?
Yeah. So usually the GLP is a very good what you call
A
invention,
tool,
okay, or the
yeah.
good drug, okay, which is there in our armamentarium. Though I am a surgeon, but I am very fond of this GLP drugs, okay, because what has happened is that the patient whose BMI is between what you call grade, that is overweight, or grade 1 obesity,
Yes,
or
sir.
grade 2 obesity, that is BMI
Yes.
between 22.5 to
Yeah.
32.5 BMI, where the surgery is not indicated, okay, then this GLP agonist helps the to lose little weight. Like previously, we used to use balloon, okay, and allurian capsule to lose weight in this type of patient. But now, because of this injectable or the oral tablet GLP and the GIP agonist, we are able to lose 15 to 18%, or sometimes 21% of excess weight also, okay, over a period of 1.5 year. So in my practice, I use GLP agonist in 4 indication, where the patient is not ready for surgery, where the patient is not indicated for surgery, that is BMI below 32.5 BMI, where the patient is not fit for surgery. Okay, old patients who are not fit patient, or
Yes,
young
sir.
patient who are not fit for surgery, and patient who are not yet thought about surgery, who want to take more time. Suppose the patient want to wait for 3 months for the bariatric surgery. In that patient also, I use a GLP so that they don't gain weight. And the fourth indication is that patient who regain weight after bariatric surgery. So I have seen a lot of weight loss in post bariatric surgery also with this injection, especially in the sleeve gastrectomy. Whenever there is a weight
Yes.
regain after 2 years or 5 years down the line, I have seen around 20% of weight loss in this post sleeve gastrectomy patient also with GLP and GIP agonist.
Yes. Yes, sir. Very right. So for post gain also you're using, sir. How different is it?
Ye-
How are the sleep patients responding, and how are the bypass patients responding? Is there a
Yeah.
difference?
So if you see the mechanism of sleeve gastrectomy and bypass, it's a little different, because in bypass we reduce the gut
Yes.
length. Okay, so we bypass sometimes 200 centimeter, sometimes 300 centimeter. Okay, and in sleeve plus surgery we sometimes go about 350 also, depending upon the common channel. So in this patient, the what you call the weight loss after starting GLP or GIP post bariatric surgery is not so significant as compared to sleeve. In sleeve, post sleeve surgery, we
Yeah.
get a good result with this GLP and GIP, because what happened in sleeve, the increase in the GLP GIP natural increase is not so much. But if you add this, okay, then the insulin secretion increases and you get good weight loss in sleeve gastrectomy.
Mm.
But in bypass surgery, you don't get that same result with this. So in bypass
Yes,
surgery,
sir.
sometimes we have
Yeah.
to do revision surgery for limb lengthening.
Yes, sir.
But
Yes,
in
sir.
sleeve,
That's
definitely
what
it
I was.
helps. Yeah.
Yes, sir. So just this is just something that I keep thinking about recently. So will it
Mm.
work the other way around? Now that we are saying that we all know that post bypass procedure, the strength of GLP GIP is definitely compromised.
Decrease.
So the
Yeah.
same strength as a non-bariatric patient or
Mm.
even a sleeve patient is not going to respond like a bypass patient. So do we
Yeah.
think that if we put GIP, GLP for the patient as a first line, make them
Mhm.
lose a little bit of weight.
Yes.
I'm talking about super obese people like
Yes. Yes.
180
Yes.
kgs
Yes.
or
Yes.
200
Yes.
kgs and all of them. So we
Yes.
bring down the weight to reduce the
Yes.
anesthetic complications
Yes.
and then go ahead with the bypass surgery.
Yes.
Do you think the strength of the procedure will be altered, sir?
No, I think it will be more benefited. Okay,
Better.
because it will benefit in the terms of length of stay. It will benefit
Yes.
in terms of complications of anesthesia complication and post-op complication. And I've seen that the post-op, the length of stay is also decreased. If you patient lose little bit weight with the GLP and
Yes.
GIP before surgery, then the post-op complication, the length of stay, okay, and the anesthesia complication, and the weight loss also is little faster Okay, I've
Mm.
seen that also. So there is a lot of advantage of starting pre-op GLP and GIP before surgery also, in in super obese patient also.
In super ways.
Yeah, yeah.
Yes, sir. Yes, sir. Uh, so I think I've covered almost everything, sir. Anything you
Yes,
would like
yes.
to add on?
So I basically will say that you should have. What is my practice is that the patient who are overweight, I manage with diet. Patient who are grade one obesity, I manage with diet and exercise. Patient who are of grade two obesity, okay, that is so I manage with diet, exercise, and pharmacotherapy. That is GLP, GIP agonist. And patient who are grade three obesity above, I tell them to go for surgery. So I always tell all my patients and all that the faster you go for weight loss management, whether it is diet, exercise, or injection or surgery, it is better because the results are better. If you go before the end organ damage occurs, okay, then you will get good result.
Yes,
If
sir.
you're already having diabetes, if you're already having blood pressure, if you're already having joint problems, snoring, and all that complication, varicose vein, and that, then already there is the end organ damage. Okay, you will definitely get the benefit, but then the quality of life doesn't improve much. Okay, once the end organ damage occurs. So I request all the listeners also that if there is any relative who is having overweight or grade one obesity or anything, just consult your physician or endocrinologist or what you call obesity physician like me or Preeti, okay, and get the treatment as early as possible. Don't wait for the stage 4. Like in cancer, if you treat the disease
Yes.
early, you will get better result. Similarly, obesity is a chronic progressive disease, okay, according to WHO also. So if you treat this chronic progressive disease as early as possible, you will get better result.
Correct.
And second thing,
Exactly.
diet and exercise is the integral part of the treatment. Whether you do pharmacotherapy or surgery, you cannot escape from diet and exercise. You have to do diet exercise. There are patients who doesn't want to do diet, doesn't want to do exercise, doesn't want to stop their alcohol or smoking, okay, want to be social, want to live the same lifestyle, okay, then there will be a problem. Then there are chances of weight regain, then there are chances of complication post bariatric surgery. So lifestyle modification, behavioral modification,
Very.
diet modification, exercise is very, very important, whatever you do for obesity, because it is a chronic progressive disease.
Very rightly said, sir. Very rightly said. I don't think any of us can escape diet and exercise. I mean,
Yeah.
it has to be
You are
compulsory.
doing, I am doing my part for the diet and to maintain
Yes,
ourselves. Okay, so
definitely.
everybody
We
has to do
try.
that.
We try. We
Yeah.
try. And the thing, the beauty lies in just keep on trying,
Trying,
you
yeah.
know.
And
But of
as a
course, now
physician, we
there's a
are
lot
there
of
to
help.
help.
Yes,
Yeah,
sir.
we
Now
are
there's
there
a
to
lot of
help them.
help.
Okay, yeah. If they
Yes.
are not able to lose even after diet exercise, definitely we are there to help.
Yes, sir. That is very true, sir. All right, sir. So this is just. So, what is the most common myth about bariatric surgery? You think, sir? This will be the last question.
So, according to me, the most common myth is that okay, after bariatric surgery, I will not be able to eat anything. So, according to
Ah,
me, that is one thing. Okay, and second thing, whether I will look bad, I will look sick. Everything means everything will go inside and all that. So, because they have seen the Ozempic faces also, okay, so they are a little worried about that. So, I tell them, no, you will be looking normal if you take your protein and diet properly, and you will be able to eat everything, anything in a small quantity. So it is not like that you cannot eat your favorite food. You can eat cake, you can have this, but you have to be a calorie conscious. You have to be a mindful eater. Okay, so that is very important. So the most common myth is that I am not able to eat. I will not be able to eat. And second is that fear of life. They are
yes, sir.
worried because they must have heard one complication here and there.
Ah,
So they are worried about that complication.
yeah.
So I have to explain them, okay, bhai, this is nothing, this is safe now. What you have heard 10 years back, it is not the same thing. Like in
No.
cardiology also or in CVTS surgery also, when people used to go for angiography before, they were so afraid. Now nobody knows also whether the neighbor has undergone cardiac surgery or what you call bypass surgery or
Mm,
angioplasty and all that. So it is now safe. So like the cardiac surgery and other surgery has become safe. Similarly, the bariatric surgery also is safe, effective, feasible.
Yes, sir. I completely agree. All right, sir. Thank you so much
Thank
for
you,
joining
Preeti, for
us
it was a
today, sir.
wonderful.
Thank you,
Yeah.
sir. Thank you. It was lovely catching up. And
Thank you.
so that's all for today. Dr.
Yeah,
KK is, sir?
hope our listeners are have good this knowledge
Yeah,
about
hope they
obesity and all
had a
that.
good amount to
Yeah.
take back and
We would
think.
like to take some questions later on. If there are some questions, also we can take later on. Okay.
Yes, sir. Yes, sir.
Okay.
Definitely. I
Okay.
don't think right now there are any questions.
No
Oh,
problem.
there
Okay.
are a few, sir. Do you want me to read it out just quickly?
Yeah, if you can, if we have time, we have about 10 minutes more. Five
Yes,
ten
sir.
minutes we can get.
So my sister's age is 27, 125 kgs, height around 158. She has gallstones,
Mhm.
CSF rhinora dog.
Mhm.
Suggests both surgery in one go. Is it safe?
So CSF rhinorrhea is little different. Okay, CSF rhinorrhea means there is some leak in the what you call the base of the skull. Okay, so we have to treat that first. Okay, the CSF rhinorrhea first. I don't think so. CSF rhinorrhea is a emergency thing. I don't know whether it is why they are waiting for that. So there must be some other diagnosis for the CSF rhinorrhea. Regarding the gallbladder stones and the bariatric surgery, definitely they can go hand in hand. We can do if their gallbladder are symptomatic, and if there are multiple stones, then definitely we should do gallbladder surgery and bariatric surgery, because if you see the height is only 158 centimeter and the weight is 120 kg, so BMI will be around 50 BMI. So the the ideal weight should be around 60 kg, but she is now 120 kg, so nearly
Double it,
double the
yes.
weight. So the
Hmm.
BMI will be around roughly about 50. So definitely she
Yes,
will
sir.
require surgery. And both the surgery, that is the gallbladder surgery, the cholecystectomy, and the bariatric surgery can be combined.
Can be combined. Yes, sir. Um, all right. Another thing is, what would impact post-surgery and maintenance precautions for vegetarian people?
Pardon me, what is what?
For vegetarian, post
Huh.
surgery and maintenance precautions for vegetarian aged people.
Okay, so basically, yeah. So vegetarian age people, we usually prefer sleeve gastrectomy because it doesn't have so much malabsorption. Okay, there is
Yes.
no much protein loss in them. Okay, so usually I avoid bypass surgery in a old age group below about 55, 60, 60, basically 60, 65. So I avoid them. So if you do simple sleeve surgery, then a simple diet along with a multivitamin and little bit of protein will prevent a nutritional problem in this type of patient. And even a vegetarian will get the sufficient amount of protein, okay, in around 50 to 60% in their diet, and only one or two scoop of concentrated protein if they take, then they will get the required calorie, nothing to be worried. So I will go for sleeve
So,
gastrectomy in a aged patient.
sir, are you practicing sleeve plus procedures, sir, like sleeve gastrostomy,
Yeah,
SASJ,
so
all of
I,
that?
I definitely do a lot of sleeve plus surgery. In last 1 year, I have shifted my all bypass surgery to sleeve plus surgery, because Roux-en-Y gastric bypass and mini gastric bypass have little nutritional and little other complication like marginal ulcers and all that, dumping syndrome and all
Yes.
that. So I have shifted. So my main two surgeries are sleeve surgery, okay, for young low BMI patient, and for the high BMI patient with comorbidity, I do sleeve plus surgery. So in that we have two to three different type of surgery, that is sleeve DJB, sleeve PJB, and then sleeve bipartition.
Okay, sir. Okay. So that's what we say, SADI,
Yeah,
SADH.
yeah.
Yeah.
So Sadi and this what you call the BPD, these
SASJ.
are, yeah. So SAHA definitely I am doing this regularly, but
Okay.
BPD and the duodenal switch, they are for the revision surgery basically.
Yes.
So
Yes.
patient who are typically metabolic syndrome, or patient is having high what you call rigor weight regain. In that patient, we do either BPD or duodenal switch. But then in Indian scenario, there is a lot of what you call protein problem and nutrition problem in
Yes,
this type
sir.
of patient. So I usually avoid BPD and duodenal switch in Indian
Yes,
scenario.
sir.
Yeah.
Right, sir. So
But
it's good.
definitely SAGI,
Yeah.
that is sleeve single anastomosis sleeve gynectomy, is a newer procedure and way to go. And it has a
Yes,
promising
sir.
result. Lot of papers are there now, and it is giving a
Yes.
promising result now.
Very
And
good
sleeve DJ,
results.
yeah, and sleeve DJB for low BMI diabetic patient, we are doing sleeve DJB. That is, we
Hmm.
are transiting the duodenum at D1 and joining the jejunum to the duodenum. So it is a called sleeve DJB, the duodenal bypass.
Okay, sir. Very nice, sir. Lovely
Thank you.
hearing a lot from you, sir. All
Yeah.
right.
Thank you.
So,
Thank you, Priti. Thank
shall
you.
we
It was a
wind up,
nice
sir?
interaction. Yeah. Thank you.
Yes, sir. Same here, sir. Okay,
Yeah.
sir. Good
Yeah. Yeah.
night. Keep
Good night.
watching
Good night.
Dr. KK
Yeah.
Med Talks. All right.
Okay.
Okay. Bye, sir. Thank
Bye.
you.
Bye. Bye. Bye.